on to our next session. So next session is on psychomotor disorder from a physician's perspective. For this, I would like to call upon Professor Upul Dissanayake, from consultant physician from Sri Lanka.
And I am representing the Ceylon College of Physicians, which celebrates 67 years of existence, where I am the president. And my speech is on somatoform disorder, a physician's perspective. I'm speaking on this topic as a physician rather than a learned psychiatrist. I'm shivering here because Dr. Farid Aslam Minhas, is he around anywhere? However, at least 30 to 40% of patients I see on a day at the outpatients, I do not have a so-called diagnosis. They do baffle me, and mind you, I have only 1 year for my retirement. Why does a patient come to a doctor? They are either seeking relief for a symptom, or they are worried that the symptom that they perceive is a manifestation of a bad illness. A good doctor will identify the reason. Is it for the relief of the symptom or for the reassurance that it is not a manifestation of bad illness? A better doctor would diagnose beyond it. She will be probing whether there is something underlying beyond the bodily complaint. Let me rush you through few interesting case scenarios before we go to the boring stuff. A 35-year-old woman was brought to the hospital by a brother as she developed weakness of her right hand. She found that she could not use her hand as she got up in the morning. She looks after a bedbound mother for the last 7 years alone at home after all her siblings have moved away after marriage. What are the possibilities? Is it stroke? Is it factitious disorder? A somatoform disorder? A conversion disorder? Or is she malingering? The next patient is a 22-year-old soldier brought to Army Hospital with severe right iliac fossa pain with local tenderness, which has started the previous night. His platoon is to be sent for duty along the border with a warring country, where there has been tension during the last 2 months. What are the possibilities? Is it appendicitis, factitious disorder, somatoform disorder, conversion, or malingering? A 75-year-old woman staying alone at home after marriage of a son complains of a neck pain, back pain, headache, insomnia, constipation, and lack of appetite. She has been thoroughly investigated at the nearest teaching hospital without finding a cause for symptoms. She is distressed that she will be bedbound soon, and the son will have difficulties looking after her. What are the possibilities? Is it multiple myeloma after a thorough investigation at tertiary care hospital? Is it depression, a somatoform disorder, a conversion disorder, or malingering? A 17-year-old girl is brought to hospital with inability to walk. She has been complaining of shortness of breath for the last few days. Her parents have taken her to a general practitioner who treated her with salbutamol nebulizations, upon which she could not get up from the chair. It has been found that she had a romantic relationship with a married man recently and has been reprimanded severely. What are the possibilities? Is it Guillain-Barré, factitious disorder? Is it hypokalemic periodic paralysis, conversion disorder, or malingering? A 56-year-old man committed the ultimate sin. He had an extramarital affair, which is not sinful in Sri Lanka, but was not careful enough to hide it from his wife, which is sinful. Upon getting to know this, wife attempted suicide by taking poison. He grabbed the bottle out of the wife's hand when it fell on the floor. He was unconscious since then and was garbled in his speech. What are the possibilities? Is it stroke, factitious disorder, somatoform disorder, conversion, or is he malingering? Some of these patients seem to be suffering from illnesses not really physical? Is it possible that they're suffering from what we call somatoform disorder? What is somatoform disorder? In simplified language, the patient feels symptoms. The doctors cannot explain what is wrong with the pure medical illness, or have doubts about their physical origin. In medical jargon, presence of physical symptoms that suggest a general medical condition but not fully explained by general medical condition or by another psychiatric disorder. Therefore, these disorders are classified under psychiatric disorders, but it is not called somatoform disorder anymore. There are two classifications currently on psychiatric disorders: DSM-5, which is for the Americas, ICD-11, which is for the rest of the world. And since I am from the rest of the world, we'll go to the ICD, International Classification of Diseases. It names this as bodily distress disorder. Americans call it somatic symptom disorder. Bodily distress disorder is when there is presence of bodily symptoms that are, one, distressing to the individual, and excessive attention is directed towards the symptom, which is manifested by repeated contact with healthcare providers. If another health condition is causing or contributing to symptoms, the degree of attention is clearly excessive, and excessive attention is not relieved by appropriate clinical examination, investigations, and appropriate reassurance. Yeah. You are required to exclude two illnesses before you diagnose bodily distress disorder. Factitious disorder is when someone is intentionally putting on symptoms or signs, but not solely with the intention of getting external rewards, like evading arrest or going to jail. Malingering obvious external rewards or incentive to motivate the behavior. If you remember that 22-year-old soldier who was brought to the hospital with severe right iliac fossa pain, is it factitious disorder or is it malingering? Now, he has something obvious to gain by not going to the front. So, it is possible that he has malingering, but it's not definitely factitious disorder. In DSM-5, it is called somatic symptom disorder, which is described as manifestation of one or more physical symptoms accompanied by excessive thoughts, emotion, and or behavior-related symptom which causes significant distress or dysfunction. These symptoms, this is very important, may not be explained by a medical condition, which is simple definition compared to DSM-4, which was there earlier. In somatoform disorder and the DSM-4, there were 7 subdivisions you have to remember. And important things were conversion disorder, which was voluntary motor or sensory function symptoms, and hypochondriasis, where there was fear of having life-threatening illness. If you remember that 35-year-old unmarried woman brought to the hospital by her brother with the weakness of her right hand, it's possible that she had conversion disorder because she has neurological symptoms. DSM-5, whereas, has all-encompassing somatic sensory disorder instead of various subcategories. It is easy for me. In DSM-4, there was a criterion that the symptoms could not be organically explained. In DSM-5, it is done away with, but adds that there should be some psychobehavioral changes that should be there to diagnose it. There are other features that would suggest SSD, like vague and inconsistent history of presentation, symptoms that are rarely alleviated with medical interventions, patient's attribution of normal sensations as medical illness, avoidance of physical activity, and high sensitivity to medication adverse effects. If a patient comes and tells you, I have had lot of adverse effects with lot of drugs for the same illness, think of somatic sensory disorder. The prevalence is 5 to 7% of the general population and is higher in primary care population. These are Western data. Our prevalence seems to be much higher. As the professor in psychiatry just told us, we in South Asia find it difficult to express our negative feelings, and because we consider it unseemly, we find it easier to express our negative thoughts through physical problems. As with any other diagnosis, it is necessary to go through a good history, do a complete physical examination, because this is important to do, because it might clinch a diagnosis which has been missed in the past. And at the same time, it gives the patient a satisfaction that I have taken the patient seriously. It is similarly important to go through the psychiatric history to exclude other diagnoses like depression. Additional testings are not good to do unless, which is much necessary, to exclude the newly found differential diagnosis. Management strategy should be to help the patient cope up with physical symptoms rather and including health anxiety and maladaptive behaviors as opposed to eliminating the symptoms. You should be very careful when you suggest to a patient that the physical symptoms that she are made worse by emotion or anxiety. They are resistant to this most of the time. You have to acknowledge that the symptoms they feel are real, and the management is not completely to cure the symptoms, but to help to live with them. Medications such as benzodiazepines and narcotics are avoided as they are addictive. Early psychiatric referral is recommended. But we have this problem in Sri Lanka at least, where the patients are extremely reluctant to go to the psychiatrist because of the stigma carried. Pharmacology comes late, however. Antidepressants can be initiated to treat the psychiatric comorbidities like anxiety, depressive symptoms, and obsessive compulsive disorders. And SSRIs and SNRIs have shown efficacy with an improvement of somatic sensory disorder compared to placebo. Medication should be initiated at the lowest dose and titrated upwards because these people have a very low threshold for perceiving adverse effects, inducing another concern. Prognosis is usually bad. Longitudinal studies show that the considerable chronicity of about 90% of these cases remain more than 5 years. It is important to educate the family on the illness. They should spend more time with the patient when the symptoms are absent, not when the patient complains of symptoms, to avoid reinforcing the idea that the symptoms bring special attention to the patient. Again, we have this cultural problem. When we visit our elders, we go and listen to their ailments rather than discuss the politics or the weather. We have to be mindful of overdiagnosing somatic sensory diseases. At least in the patients with medical illness, it is better initially to call them maladaptive or extreme compared to normal reaction, not labeling them somatoform disorder. In those with no diagnosed medical illness, it is necessary to encourage routine than symptom-based visits. You tell the patient to come at such a time, not when they are symptomatic. And during these visits, adequate and repeated medical workup should be done to uncover medical conditions that may present with time. Coming back to the patients I mentioned initially, that 35-year-old unmarried woman who was looking after the mother, who had weakness of the right hand, of course, had somatic symptom disorder or the bodily distress disorder. The 22-year-old soldier whom we thought is malingering had a real appendicitis. The 75-year-old woman staying alone at home after the marriage of her son, complaining of neck pain, chest pain, back pain, headache, insomnia, constipation, and lack of appetite, and all that. She had multiple myeloma, which was not picked up during the initial presentations, and it was on subsequent investigations only it was found out. The 17-year-old girl who was brought to the hospital with inability to walk, who was nebulized by the GP and could not walk, and who had the affair with the married man. She had distal renal tubular acidosis. Her shortness of breath was due to normal anion gap acidosis and the muscle weakness due to hypokalemia. The 56-year-old man who committed the ultimate sin, he had intracerebral hemorrhage. Take home message: people who have somatoform disorder are not faking their symptoms. What they feel is real. Acknowledge what they feel is real and not imagined. Discuss with the patient initially SSD as a differential diagnosis for their problem as you start the workup. Listen to your patient. They will give you the diagnosis. Ladies and gentlemen, Ceylon College of Physicians invite you to visit Sri Lanka during its annual academic sessions, 2022 September. Your president, Professor Javed Akram, has promised us that he will be there as a guest of honor. We'll be sharing further details with the Pakistan Society of Internal Medicine, and we are open for the abstracts. Thank you.